Can you hear me now? There you go. So, huge topic, 20 minutes. So we'll go through fairly quickly. But as Doreen said, the slides will be available for in a few weeks' time. I have no disclosures. When we talk about pelvic floor disorders, the most common ones are urinary incontinence, stress, urge, and mixed, and also anal incontinence, which involves leakage of feces or stool, leakage of gas, and also a lot of women have problems holding or deferring defecation for more than 15 minutes. And we also have pelvic organ prolapse, but I won't be going into pelvic organ prolapse today. Incontinence significantly reduces quality of life, and embarrassment is a major issue, specifically for anal incontinence. And restricting social activities, going out, going to the shops, normal everyday life. And also what we know is because of embarrassment, few women actually talk about incontinence, and they would like us to ask them rather than having to volunteer the information when they see the doctor or the physio or the midwife. So we have also a lot of economic consequences, both when it comes to cost of rehabilitation and management, but in unpaid and paid work as well. If you're a hairdresser or a teacher even, and you can't control gas, it might be a problem, just both with sort of smell and sound as well, with uncontrolled leakage of gas. And not being able to take your kids to school or going to see a football game also is part of the economic consequences, as well as reducing quality of life. In 2010, the average cost was about $4,000 per patient with stool incontinence, which might not seem as a lot of money, but if we add on the cost of urinary incontinence alone, which exceeds more than 20 billion American dollars, and that was from 2007, it's quite a lot of money, and it actually is more than the estimated cost of other diseases such as arthritis, influenza, and pneumonia. So if we can do something about it and preventing these symptoms and dysfunctions from occurring, would be an economic perspective as well. Prevention is trying to stop something from happening. And if we're going to try to stop something, we need to know why it happens, the causative factors. When it comes to incontinence, general risk factors, we can't do much about age or ethnicity, but we can try and look at factors such as diabetes and obesity and reduce the prevalence of those factors and see if that actually reduces the prevalence of incontinence. But we're talking about pregnancy and delivery today, and a lot of the factors are associated with hormonal and mechanical changes that occur during pregnancy and after delivery, and as well as injury to the connective tissue and nerves. But recent studies have shown that it's the first pregnancy that makes the most damage, and that's when most women actually experience new onset of anal incontinence, urinary incontinence, in relation to the first pregnancy or first delivery. And specifically the women who have pelvic floor muscle injury, and those who have injuries to the anal sphincter muscles. And about 50% of women who actually deliver vaginally have they lose some of the supporting function of the pelvic floor muscles during childbirth. And about between 1 in 4 and 1 in 5 women actually have major injury to the pelvic floor muscles. And unfortunately, these injuries have not received by far the same attention as the sports-related muscle injuries. So it would be nice if these women actually got the same attention and follow-up as a sports person for a strained hamstring. But we know that physical activity and exercise are essential elements of a healthy lifestyle, and overall physical inactivity is actually the 4th leading risk factor for early mortality. And in pregnancy, we know that physical inactivity and weight gain actually increases the risk of maternal obesity and complications such as diabetes. And if you remember back to the previous slides, diabetes is one of the major risk factors for incontinence in the first place. But there are lots of benefits of exercise in uncomplicated pregnancies. You increase the aerobic capacity and fitness. You have fewer operative deliveries, fewer cesarean sections, and they recover quicker than those who are inactive. And also, it can modestly reduce weight gain during pregnancy. And an abstract being presented here today, this week, they compared women who started doing exercises before 6 weeks after delivery, regular exercise 3 times a week or more, with women who didn't do any exercise or were inactive, and they found no difference between the inactive and the active women when it comes to pelvic floor muscle function, urinary incontinence, and pelvic organ prolapse. Unfortunately, there were only 2 women in the study who reported anal incontinence, so we don't know, or they couldn't report on any effect on anal incontinence. But the recommendations in pregnancy, as for the general population, is 30 minutes a day, 5 times a week, or 150 minutes of moderate aerobic exercise, equivalent to a brisk walk, which needs to be adjusted individually. There are some absolute contraindications, and I won't go into them. They're all in the report by the American College of Obstetrics and Gynecology from 2015. But they do recommend a few activities that these women need to avoid during pregnancy. Contact sports, such as handball, football, ice hockey, and activities with high risk of falling. Scuba diving, problems with, particularly the fetus, with adjusting to the pressures. And also skydiving, and hot yoga with temperature adjustments. Again, relative contraindications, that needs to be looked at individually, but the recommended and safe activities for most women with uncomplicated pregnancies are walking, swimming, cycling, and low-impact aerobics. They may also do modified yoga and maybe avoid positions including supine lying and also holding positions for a prolonged period of time. If they're used to running or jogging, there's no reason why they can't be doing that in pregnancy. But if you haven't been doing jogging or running, this might not be the time to start. So, and last but not least, strength training is part of the recommended activities. And we're going to look a little bit more about that, but we need to think about the warning signs. If the pregnant woman is feeling unwell, dizzy, shortness of breath, she experiences bleeding or a leakage of amniotic fluid or any of these warning signs, we need to stop exercise and consult a physician. But the aim of pelvic floor muscle training, as for any strength training, is to improve muscle strength, endurance, and coordination, which will improve function. And the way to do that for most strength training and also pelvic floor muscle training is to perform 3 sets of 8 to 12 close to maximum contractions 3 to 4 times a week. And we also need to have a certain degree of progression throughout the period as well to maintain or increase muscle strength. So what happens when you do strength training? The increased muscle strength is usually related to the increased number of recruited motor units, which leads to increased muscle volume and hypertrophy. You have an improved timing of the contraction due to the increased speed of recruitment of muscle fibers. And also you get the increased stiffness of the muscle connective tissue complex. And there are lots of theories why pelvic floor muscle training might prevent or treat pelvic floor muscle disorders. And this is from a Norwegian study. Strength training shortens the muscle length and elevates the bladder and the rectum. It increases muscle volume and thereby improves closure of the levator hiatus. This combined improves the structural support and the connective muscle tissue complex, and improves automatic function, because normally after you stop using diapers, this is something that you don't really think about holding. You can go to the toilet whenever you want to. So when these women have problems, we need to look at the automatic function as well. Another theory on how we might change or affect pelvic floor muscle dysfunction is behavior modification. For instance, if women do contractions, active contractions of the pelvic floor prior to coughing or sneezing, you might prevent leakage during coughing and sneezing. And also muscles, or well-trained muscles, they are less prone to injury, and if you do sustain an injury, they are easy to retrain because the motor patterns have already been learned. So if we look at the evidence, latest Cochrane review of pelvic floor muscle training for reducing urinary and fecal incontinence during pregnancy and after delivery. We see that if we look at primary prevention, which is offering pelvic floor muscle training to women with no incontinence symptoms, we see that it reduces the risk of urinary incontinence in late pregnancy and up to 6 months after delivery, but there's insufficient evidence between 6 and 12 months after delivery. If we look at anal incontinence, no studies have actually reported on anal incontinence or primary prevention of anal incontinence. And a lot of the studies that look at anal incontinence or report on anal incontinence have been designed for urinary incontinence, which is a lot more prevalent than anal incontinence. So there are too few women actually suffering from anal incontinence. So a lot of studies cannot actually say anything like the study before that had 2 anal incontinent women, which is a major problem. This is a Dutch study it's like an internet-based study looking at the willingness to participate in preventative pelvic floor muscle training. And 95% were interested in receiving information, either from the healthcare professional or through a brochure, but only 30% were interested in participating. 12% were doing their exercises already, and 40% were actually hesitant or not quite sure if this was anything they wanted to do. And the willingness to participate was influenced by their own perception of health, if they had any symptoms of urinary incontinence or POP, and how far they had to travel, as well as the cost, how much it would cost them to actually attend these classes. So these are factors that we need to take into consideration if we're actually planning pelvic floor muscle training groups. If we look at treatment and pelvic floor muscle training, offering training to women with existing symptoms, we don't know quite about the effects in pregnancy, and the effects remain uncertain after delivery as well. And the results are unclear beyond if you have pelvic floor muscle training after delivery. And there's generally very low quality evidence, in most of these studies, included in the review. When it comes to anal incontinence, the results during pregnancy are uncertain. And again, no trials reported on postpartum anal incontinence or treatment postpartum. If we looked at mixed prevention, which is offering treatment to women with and without symptoms, you can see that there's a reduced risk in late pregnancy and up to 6 months after delivery. But the effects are uncertain beyond 6 months postpartum, and particularly if you offer training after delivery. And again, with anal incontinence, there's little or no effect of treatment before delivery, and a certain effect if you offer pelvic floor muscle training after delivery. And in general, quality of evidence is low. And what about the long-term effects? There is insufficient evidence of the long-term effect beyond 12 months. And a lot of studies have been conducted on women who are first-time mothers. And strangely enough, they tend to go on to have more children. And we don't know how that will affect the effect of pelvic floor muscle training, and how the multiple pregnancies and deliveries actually impact on this. And there's also, we don't know much about long-term adherence to pelvic floor muscle training. So Woodley and co-workers actually conclude that it might be better to target women at risk or women with incontinence symptoms rather than offering it to everybody. And mostly because we don't know much about the cost effectiveness of offering pelvic floor muscle training to all women. And this has been further supported by a recent study that was out in March, they compared general strength, muscle strength, grip strength, quadriceps muscle strength to pelvic floor muscle strength, and they found no association between general fitness and muscle strength with pelvic floor muscle strength. So they conclude that targeted intervention, specific structured pelvic floor muscle training is probably the best way to increase pelvic floor muscle strength. So it might be that we're actually back to prevention being what we need to be looking at. Thank you.
Yeah, okay. Thank you very much. We'll see if we can have a few questions. If you just would come to the microphone and introduce yourself if you've any questions. Somebody here.
My name is Patrick Meffin. I'm from New Zealand. I enjoyed your talk. In the area of exercise and just general health in the general population, there's been a real move recently to the idea of high intensity, more strength based rather than just low, the 150 minutes a week. Mm-hmm. When you started talking about strength training, you really only talked about that role in pelvic floor exercises, and I wonder whether in the general advice to women that 150 days of light walk, 150 minutes a week of light walking actually should be modified and should reflect what's currently seen as evidence in just general health, that it should actually be a little bit more mixed between intense strength stuff and the rest.
Absolutely. We know that about 30 to 40% actually reach the recommended levels of physical activity in the general population in the first place. So I think absolutely we need to adjust what needs to be done. Maybe Kari can
I just want to add on that, because I think the recommendations from the WHO and American colleges is really to add strength training 2 to 3 days a week. It's not to go on less aerobic exercises, but to add strength training.
Any other questions? I would just like to ask a question. So we see maybe elite athletes going back to their sport quite quickly after having babies. What would your general advice to be for a woman who's had a normal delivery, maybe has had a couple of stitches, but otherwise is quite good? When do you think they should start training? If they play hockey or if they go out and do jogging, how long postpartum would you say?
Like I said, I think that's sort of an individual evaluation that you need to take. Mm-hmm. If they have problems with incontinence, which they might have before delivery, which makes them more prone to having problems afterwards as well. But having a strong pelvic floor would be one of the recommendations, or somewhere to start. But if elite athletes tend to go back to activity quite quickly. So making sure that including pelvic floor muscle training in the exercises, absolutely.
Birte Bunde, physiotherapist from Denmark. I just wonder if you have looked upon sexual life also, because you looked upon urinary incontinence and anal incontinence. How about sex life and pelvic floor training after giving birth? Because there's not an option with sex there.
No, I haven't looked at that now, but because I wasn't sort of part of the scope of this presentation for 20 minutes. But definitely it's a big issue with pain. I will talk about later on today, even though it's made pain, some will be applied to.
but also the enjoyment of it.
Absolutely.
Merete, physiotherapist from Norway, just to add on as her, we find that pelvic floor muscle training following the first delivery actually made the women feel sort of narrower or tighter, so that also might be positive for the sexual life.
Thank you.
Okay, thank you very much. Thank you.